Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts. Hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, I'm Dr. Michael Koren, the executive editor for MedEvidence. And Dr. Seth Baum and I were having this fascinating discussion about cardiovascular disease death rates and how we're using clinical trials to work on reinstituting a trend towards lower mortality, which kind of stalled over the last 10 years. So we'd invite you to go back to the previous talk, if you haven't heard that, to get a little bit more information about what's happening epidemiologically. But now I want to talk to Seth, who is a fellow cardiologist and a fellow clinical trialist, about what we need to do to keep our patients engaged when they get involved in clinical research. And this is so important because the success we've had to date has involved people staying in statin trials and other cardiovascular risk reduction trials over an extended period of time. And in order for us to have continued success, we have to encourage people now to get into trials with new therapies and to stick with those trials. So Seth, start us off by letting us know, when you recruit a patient from the very beginning, how you think about retention issues and keeping them in trials.
I think that's a great question and a great point, because retention in a cardiovascular outcomes trial is paramount, right? If you have a high dropout rate, your data are going to be terrible. So, and you won't be able to prove your point if it's provable. So,
and by the way, good products have gone by the wayside because of flaws in the trial and flaws with retention. So at the end of the day, if people don't complete the trials, you won't know if the product actually works.
Right. So the discussion with the participant, in my view, has to happen day one at the time of signing of consent. The discussion really should center around the fact that it's a cardiovascular outcomes trial that has to be explained. The value of a cardiovascular outcomes trial has to be explained. For example, we know from a good deal of data that participants in cardiovascular outcomes trials who are on placebo have lower event rates, much lower event rates than their counterparts in the real world.
Isn't that crazy?
It's crazy.
It's crazy. And sometimes we call that the Hawthorne effect.
Yeah.
Do you believe in that?
So I'm not sure what the cause is in terms. I have some ideas what the cause is in terms of specifically a cardiovascular outcomes trial. But I think it's clear that it's that being in a trial, in a long-term cardiovascular outcomes trial, participants do a number of things, such as adhere to therapeutics, right? Have
more interaction with the healthcare system,
more eyes on them. They take it more seriously. There are so many factors that come into play that can lead to this benefit. And interestingly, Eugene Brunwald has been quoted as saying that were he to have a cardiovascular event, a heart attack, let's say, he'd like to be enrolled in a cardiovascular outcomes trial and placed on placebo. So, yeah. So I think there's truth to this.
Eugene Brunwald is arguably one of the most famous cardiologists in the country. He's in his 90s now.
He is. He's like 93, I think, 93, 94. He was a mentor of yours, right?
He was an attending physician when I did my third-year medicine clerkship at Beth Israel Hospital in Boston. So I had the great privilege to be one of his mentees.
Yep. So we have that discussion. We really actually go through this. Everything we're talking about now, we really discuss with the participants. We get them to agree that their intent is to stick with the trial. Now you can't strong arm people, and force them to do this, but certainly from the outset of a study, they need to buy in. Otherwise, frankly, they should not be included in the study.
Mm-hmm. Yeah, and that's a really, really important point. Is you can identify people who may be getting into the study for the wrong reasons, and it's very important that you call that out if you identify that behavior. So if somebody gives you the inclination that they're going to try to cheat and find out what they're on and use that information to determine whether or not they stay in the study, please don't include those folks because it hurts the participation of everybody else.
Yep, it's true. And then moving on from that initial visit, I would say probably the most important factor that will help retention is having a good interaction between the study participant and the staff. That includes the coordinators, the investigators, the front desk, frankly, a shorter wait times for an appointment. Everything's got to move smoothly, and the participants have to be happy, and they have to look forward to coming to the site. Yeah. When things go wrong, a quick call, a conversation, that kind of thing can go a long way as well.
Yeah, clinical trial as a service. Unfortunately, in the current medical environment, a lot of clinical care is very rushed. People don't feel the service element of routine clinical interactions, but we can give them that experience in the clinical research realm. So I think it's important to emphasize that, as you point out. So that's a really, really good point. How about other little things, little perks, little educational tidbits? Do you find that works?
Educational tidbits in terms of educating the participants you're talking about?
Yeah, making sure that there's something that is provided to each participant that's individual to them at each visit that makes them feel that they're getting a special education being part of a clinical trial.
Well, I'm not sure whether you have a particular thing in mind, and I'd love to hear if you do. But certainly, what we do, and I would emphasize others do, is at each visit to have the discussion to reinforce why the participant is in the study, reinforce, for lack of a better term, good behavior, adherence, reinforce the value to the participant and, frankly, the value to the world. It's both. And even to reinforce that the fact that we know that if the participant is on a placebo, the participant is still getting benefit from being in the study. So those things are what we do, and I'd love to hear what else.
Yeah, you touched on a number of things that are really important tactics. So I'll give you an example of specific value. So I practice what I preach, and I eat fish most days of the week. I don't know if you're a fish eater or not, but
I don't like fish.
Okay. Well, I'm a big fish guy. And so I will share with patients my recipe for halibut, which is my favorite fish to prepare at home. And not that I'm a huge cook or anything, but I love to actually cook fish at home. And I have this recipe for a mustard halibut that I'll share with a patient, and people love that. Or I'll tell them how you can use how to get more omega-3 fatty acids in their diet through different things. And then your point about this concept that we share our data and our experiences with other investigators from around the world, people are fascinated by that. So I'll tell them a story about how people like you and I will go to the American Heart Association meeting and give a presentation or write a paper and how important it is. And that at the end of the day, their participation gets amplified to physicians and other healthcare providers around the world. So the experiences here in Florida actually will change behaviors in India or influence people in Germany, et cetera, et cetera. So to me, that's an exciting part of that. And I think patients get a kick out of that, to know that. And they otherwise wouldn't have that knowledge unless we engage them at that level.
Yeah, I think that's great. Those are great tactics you utilize. It's very nice of you to share your halibut recipe. And I think my wife.
It's a secret. You have to be. Only if you sign up for a clinical trial will I reveal that secret.
You got to let me know for my wife. I won't eat it, but she would love it. So.
Yeah, the IRBs have looked at that as coercion, but I got it passed.
That's funny. It's that good that it's coercion.
It's that good. Yeah. Anyway, but people love that, and again, they actually need little tidbits and tips to help them complying with exercise. A lot of people have the right intentions, but they don't know how to master the logistics. And I think part of the conversations we can have help them master those logistics.
Yeah, and the reinforcement they get when they come to the site is invaluable. When you reinforce those behaviors and you acknowledge when they're doing things that are are benefiting themselves. I think that's very valuable. The connection to the rest of the world is really valuable as well. And we have those discussions too. And participants typically genuinely appreciate helping the world. And it's
absolutely.
true, right? You and I, as clinicians, help a lot of patients. But as in our clinical research, we help millions and hundreds of millions of people, right? Billions of people in some studies, right? So like in Lp(a), it's going to be billions of people. So,
No doubt. Yeah, and the flip side of that, by the way, is if a patient drops out of a study, particularly if we kind of lose contact with them, then what happens is that data point gets lost, and there's a possibility that will compromise the study to the point where we don't learn the truth. And not only does that have an effect on the individual who's the one that dropped out, who won't get the feedback and the information that comes at the end of the study, but that'll affect the participation of everybody else that's participating in the study potentially. So I think most people, even if they're fed up or they're tired or they're fatigued, they don't want to compromise the experience of other people, right, and making them aware of how that works. So just to fill in a detail there, if you get lost to follow-up in a study, we often have to assume that you've died, whether or not you have died. So for statistical reasons, you look at as somebody that has had an event that will perhaps create some impact on the entire study, because that's an inaccuracy. And with that inaccuracy, you won't know the real truth.
Right.
So these are very, very important concepts to let people know about. The other concept that's important is that let patients know that they can stop taking the study medication but still be in the study.
That's a great point, because some investigators are confused about that and believe that if they stop the investigational product, the patient stops, then that's tantamount to withdrawal of consent, and it certainly is not. So we like to follow our patients throughout till the end of the trial. Even so optimally, we want them on an investigational product. If they can't be on investigational product, we want them coming in for all their visits. If they refuse to go in for all their visits, we say, how about on the phone? If they refuse on the phone, we say, okay, let's check in with you, once a year. If they refuse that, okay, we'll check in with you at the end of the study.
Exactly, that's right. Right.
So we have this hierarchy of our preferences, but we never, ever want to go down the withdrawal of consent road if we can avoid.
Right, and even if we just know their vital status, that is better than the alternative. And the other thing to point out is that often we find out things during the course of the study that benefits patients who are on the active product, and often the sponsors will make that product available to patients if they stick with it. So there's been a number of examples where investigators like Dr. Baum and myself are lobbying the companies to allow people to have open label access to these products at the end of the study. They don't always do it, but often they will. And that really depends on people sticking with the program so that they may get access to those products.
Right. Yep.
It's an important point. And then, it's always just good to be charming and to let people know that they're valued. People need to hear that. And that you'll do whatever you can to help them in ways you may not anticipate. So sometimes people come in and they personally don't feel like they're getting anything out of the study, but they mention a family member. And for the staff and physician to be open to figuring out what you can do. So, for example, you mentioned lipoprotein(a) or Lp(a) as what we like to call the really, 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 really bad cholesterol. And for example, you have resources for people, including family members, to get this tested for free.
That's true. Through the Family Heart Foundation, you're absolutely right. And they could certainly go online and look into that. There's also the cascade screening. So we encourage an individual who has elevated Lp(a) to have the entire family, first starting with the first degree relatives, then moving out, tested for Lp(a) to identify at-risk individuals. And that's very important. We do that for familial hypercholesterolemia as well. So these genetic disorders, they're family diseases. They're not individual diseases. Very, very important and a real benefit to the participant. There's another benefit as well. You bring up, valuing them and just being nice. We do see lab aberrations during the course of a study, and often the investigators will call the participants' physicians and have a discussion and bring something to their attention that they otherwise would not have been aware of, and that can really impact the participants' health.
Oh, great point. And multiple times we've picked up other things during a study that have made huge differences in people's lives. So really good point. Again, as clinical investigators, we have an attention to detail that's absolutely required that really results in things that do affect the people who are in the studies, whether or not you're on the active drug. So I think it's a really good point. Seth, this has been an amazing conversation. Hopefully, we'll share it with a lot of people. Hopefully, this will help other physicians and patients understand the importance of sticking with it once you get involved in a study, particularly a long-term outcome study, which can lead to fatigue during a period of time. But it's really important that people understand why sticking with it makes a difference, both for themselves, for their family, and for society at large. So thank you for the conversation, and we'll definitely get you back to MedEvidence and talk about some other things in great detail. Thank you, Seth.
It's been a lot of fun, Michael.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.